So I'll basically be continuing on where Philippe left off, and I'll be talking about some of the kind of research that has gone on, implementation research that was gone on when I was with the WHO TDR, and I continue to do this now in collaboration with TDR WHO, but while I'm at McGill University now. And I think it's an example of the kind of research that actually needs to be done in the field. There's a lot of wonderful research going on in the laboratory, and ultimately that's what's going to lead to the elimination of this parasite. But for the short term, there's still some very important research that still has to be done in the field. And I think people who are in the endemic countries also have to keep this in mind, that you also have, there's many questions that still need to be answered as to what's going on in the field, and you can actually start to address some of these issues as well. So the elimination of visceral leishmaniasis through implementation research, and I'll talk a little bit about what has gone on over the last 5 or 6 years at the WHO TDR. First of all, the elimination, there are a number of elimination programs at the World Health Organization, but that does not mean the disease is gone. By the WHO standard, elimination means you're bringing down the number of cases to 1 in 10,000 in the highly endemic region. So there's still actually quite a few cases here. Even though you've eliminated the disease by WHO standards, you still have a lot of people with the disease. The reason they use the term elimination is because it's eliminated has a major public health problem, but it doesn't mean the disease is eliminated. To get rid of a disease completely, you have to have eradication. So there's a difference between elimination and eradication. There are a number of things that have been focused on to reach this elimination of 1 in 10,000. And I would say these are the 3 most important ones. Case detection in the endemic village. You've got to find the cases and treat them. Vector control, and the other one is diagnosis and treatment at the community level. So these are 3 of the major focuses that are required for trying to reach this target here. And I'll talk about each one of these and some of the efforts that have gone on these in the last several years, with a focus on the Indian subcontinent. And the Indian subcontinent, if we look at DALIs, this is a sort of snapshot of major infectious diseases, of course, HIV, diarrhea, malaria, tuberculosis. And if you look down the list here, leishmaniasis is quite high on the list, but if you look in Southeast Asia, which includes India, Nepal, and Bangladesh, it's 67. It's actually higher. It's the highest one in Southeast Asia. So this is really a major problem in Southeast Asia, particularly India, Nepal, and Bangladesh. So the benefit of targeting an elimination program is to try and bring this kind of number down. So there's a real need to do this. This is a slide which I'm not even sure why I have it in here. All of you know this slide. This is how it's transmitted. So as sandflies, you have the promastigote, which bites an individual, enters into the macrophage, and the amastigote form in the macrophage, which replicates and then is taken up by the sandfly. And this is the life cycle. Philippe gave you a lot of details about the different reservoirs, rodent being the major one for cutaneous. But for visceral leishmaniasis, Leishmania donovani, humans are the reservoir. So we're focusing really at this stage where humans are the reservoir. So what are some of the opportunities for elimination? What are some of the advantages of working on elimination programs? Well, one advantage is that humans are the only reservoir for L. donovani. So this makes things easier because you don't have to worry about rodents, you don't have to worry about an animal reservoir, you can just focus on humans. And it's a lot easier to deal with humans than, for example, a rodent reservoir. So this is one advantage. Another advantage is that there's one vector species responsible for visceral leishmaniasis on the Indian subcontinent, and it's quite amenable to vector control. So there is ways of dealing with the vector, and I'll be talking about some of those approaches in this talk as well. And the other thing is that geographically, and I'll show you in an upcoming slide, it's very focused, the disease. It's not spread out throughout the continent, but in fact, it's very focused in some areas. And that's also an advantage, because you don't have to have a program which is countrywide. You can just focus on the areas where you have most of the cases. And we also have much better tools to deal with the disease right now. For example, drugs, we have at least 3 new drugs over the last 10 years, ambisome, miltefosine, and paramomycin. So this is in addition to the old drugs of antimony. And we can also carry out diagnostic tests, which are very rapid to detect people who have antibodies against the parasite. So we have better diagnostic tests, better drugs, and we have a strategy here. So can we put these things together and start to reduce the cases? So again, this is the point that I was making on the last slide. This is the area where you have probably 50%, or at least up until a few years ago, 50 to 60% of all the visceral leishmaniasis in the world is focused in this part here, which borders India, Nepal, and Bangladesh. So this is a fairly focused area where you have most cases. So a lot of people say, why this? Why are there so many more cases here than anywhere else in India? And I think it's a good question. I think there are probably many reasons, but this part of India is in fact the poorest part of India. So not only do you have visceral leishmaniasis here, but there's still quite a lot of cases of leprosy there. This was the last place where you had polio eliminated. There's a lot of malaria in the area. A number of encephalitis viruses are in that area. Virtually, this part of India suffers from not only high levels of visceral leishmaniasis, but almost any tropical disease as well. So, and I think there are a number of reasons, but the biggest reason is probably poverty. Poverty and disease go hand in hand, so the more poverty you have, the more disease you have, including visceral leishmaniasis. So one take-home message is that we work at one disease at a time, but maybe in a long-term strategy, and this is something that you could probably pursue, is that if you deal with poverty, I think you'll also have a major impact on a lot of diseases. So where are we going? Well, this is a typical village in the Bihar area. You can see very colorful people here, and this is the typical area where you have many sandflies. This is perfect breeding grounds for sandflies. A lot of them prefer to breed inside the homes where it's darker and damper, and sandflies, they're not very good flyers. They're not like mosquitoes, which are big and strong. Sandflies are very small and weak, and so they don't fly very well. So they prefer surviving in houses rather than in the open. So this is a typical village where you would have high levels of visceral leishmaniasis. This is in the rainy season. And again, this is in Bihar. And one of the things that always strikes me is that there are also high levels of soil-transmitted helminths in this area. And one of them being hookworm, where it can be transmitted through bare feet this way. And it's easy to say, okay, everybody start wearing shoes. But in fact, it's a very difficult thing to implement, everybody wearing shoes in this type of area. Virtually nobody does. It's just so wet all the time. So this could be helminths. And helminths, as many of you know, may be another risk factor for leishmaniasis because it alters the type of immunity that's required for dealing with leishmaniasis. This is a school. I took this picture last summer. Really, these are the children here at school. And this, they have their uniforms here, the classroom. It was actually quite a nice afternoon. And they do have an anti-helminth program going on now, which I think is going to be very helpful as well. So all of these children do get treated twice a year with anti-helminthics. Okay, so where are we going with the leishmaniasis? So case detection in the endemic villages. Okay, fine. Let's go find all the cases in the villages and treat them. But how do you do something like that? Because you have thousands of villages. So how do you start to work in 1,000 villages? It's a very difficult thing. You can do it in 1 or 2 villages, but to do it in 1,000 is, you need a plan. So the approach we've started to take through the WHO in collaboration with the ICMR in India, okay, I'll talk about that, but where we're focusing our areas is this is in the Bihar state, and these are 2 districts, Saran and Varshavy. These are two areas where you have amongst the highest cases in the world. And within each of these districts, I think there's 30 districts or 31 districts in Bihar. About 10 or 11 of them are highly endemic. And within each district, there are called PHCs, or primary healthcare centers. So these are an area where you would have 2 or 3 doctors, several nurses, and they would be able to treat the local villages. And there may be several hundred villages which are treated by each of these PHCs, primary healthcare centers. So they have each a geographic region that they take care of within the district. So our study is focusing in 2 districts, Muzaffarpur and Saran, and these are the primary healthcare centers that we're working in. And the reason we chose these 4 is because they have the highest number of cases. So we're sort of setting up our study, and our study is ongoing in these primary health care centers. And our strategy is to work with women in these villages. And each village has what's called an Asha. I'm trying to remember Asha. Who can tell me again? It's accredited social health care activists. So these are women who live in the village. And initially, this was set up so that they could look over the maternal health within the village to help to make sure that children are delivered at the primary health care center and not in the village. And they look after the newborns, and they look after the women in the village. But every village has one of these Ashas now. It's a very successful program in India. And these Ashas know everybody in the village. And there's about 1 Asha per 1,000 person. And so these we saw has a potential resource to help us with our program in visceral leishmaniasis. And so we set up a training program. One of the nice things about the training Ashas is you don't have to go into every village and train an Asha. Every month they have what's called Asha days. And all the Ashas from their surrounding villages go to the primary health care center, and they discuss local things, local issues which are going on. And that's what we targeted. So this is an Asha day. This is Dr. Das here. And we set up a training program, which takes about an hour, and we explain to the Ashas what are the symptoms of leishmaniasis, how it could be transmitted, what they should do and to educate these Ashas about visceral leishmaniasis. Some of them already knew, but it was amazing that some of them, the majority of them really didn't have a very good understanding of what visceral leishmaniasis was, or what to do if somebody had visceral leishmaniasis. So this is just another case of these are the uniforms that they were wearing on that particular day. And so what we do is we train the Ashas. The other thing we do is every Asha is given a poster, and it's made out of a hard plastic material. And this is the poster here. And these posters are put in a prominent part of the village. And it basically describes the disease, how it's transmitted, what are some of the symptoms, how it can be identified, how it can be diagnosed. So if someone has to have a diagnosis, this is the test that's done. That treatment is available, how to protect yourself. And the most important thing is probably here. And what it says here is that do not pay for treatment. The treatment is free if you go to the primary healthcare center. Because previously, as Philip was saying, they would be treated by local quacks, and many times the quacks didn't have the proper medicine or didn't provide the proper medicine. But in this education program, drugs are now available at the primary healthcare center, and people should not have to pay. Everything is free, the diagnosis is free, the treatment is free, and you should go for the proper treatment at the primary healthcare center. And I think this has probably been the most important advance in dealing with the disease. So we've now gone through 2 training sessions. We've trained about 1,000 Ashas, which covers a population of about 1 million people. And after the first round of training, so they just went through 1 training, we saw that the referral rate by Ashas, initially it was less than 10% of the cases going to the PHC were referred by Ashas. After the training, the first round of training, that went up to 27%. So we had a jump in referrals from 10% to 27%. We then did another round of training, and now we're up over 50% So 50% of the people going for treatment, they're being referred by the Ashas. And before that, it was less than 10%. So it indicates that the training of the village Ashas is actually having an impact and having people moving from the village to the PHC to be treated. These are very simple things, but in the long run, they're very important for the elimination program. So this is some of the other work we're doing here. This is Tarwa village. This is in Saran. This I call ground zero. This was taken last summer. I took this picture, and there were about 40 cases of visceral leishmaniasis just in this village. It's a fairly small village, and I call this ground zero because within the Tarwa village, in this area, there were 6 cases of visceral leishmaniasis just within this, people living in here. So this had the highest concentration of visceral leishmaniasis probably in the world. So these are interesting places as well to try and understand, why this village? Why did this village have so many more cases than another village? And that's another question we don't really understand. So this is a question I put open to everybody here. Why do some villages have such high levels of infection, and another village 1 or 2 kilometers away would have very few levels of infection? It's not a sort of even spread. So we're starting to try and address this question. So one thing we're doing, we're working in 15 villages like this, and one of the things we're doing is we're diagnosing everybody in the village. So we have a log where we have each family has signed a form, and everybody in the village is being diagnosed. So a drop of blood is taken, and we look for antibodies against Leishmania with the RK39 test. And we're doing this for 2 reasons. Number one, because there are very high levels of VL here, we want to catch everybody as soon as possible and make sure they're treated. And the other one is we're trying to understand how the disease is moving within the village. How is it moving around within the village? How is the infection being transmitted within the village? So this is just another picture here taken. I'm using a magnifying glass to read the RK39 test because sometimes it's difficult to see very faint bands. This is Bianyapur, another village that we're working in. And in general, people are very receptive to this because they're starting to understand the disease now, and they see people start to gather around where we're setting up these stations. Let me just, I'll go back a bit. There's a lot of support, there's a lot of buy-in for this type of study. So one of the things we're finding is the following. So this is a log book. This is a typical log book where we're looking at serology. We're looking at who's got the infection and who doesn't. And each one of these groups is a family. These are a group of people that live together within the same dwelling. And if they're positive, we keep the strip, and their name is, and they're given a sign here, positive. But what we find is these green ones are asymptomatic. So these are people, they don't have disease, they're healthy, they're normal, they don't have fever, but they have antibodies against Leishmania. So we consider these people as asymptomatic. The one in red, these are people who have the disease. So these are visceral leishmaniasis cases, they're positive, we keep the strip. And what we're doing is we measure their family as well. And every 6 months, we go back to the family, and we redo all of these measurements, and we want to see if there's any transmission occurring in this household versus this household. We're trying to understand how the disease is spread from family member to family member. So this is a prospective study. So we have parts of the village, for example, where we have here a group of visceral leishmaniasis cases, all living closely together. We have another group here of asymptomatic infections all living together. And then, of course, we have here where there's no asymptomatic, and these are control people. So we're trying to see how the disease is spread. Every 6 months, we go back to this area, test everybody here, test everybody here, and we're trying to see how the disease is being spread in these different situations. This is Dr. Pandey, who's part of the study. He's coming out of Patna. And this is one of the screening tests, the screening serology that's going on. You can see here's the poster here. This is the tree, so this is where we have the poster. And one of the things that Dr. Pandey does, when you go to the village, you don't only screen for leishmaniasis, but he also has an open chair, and he says anybody who's got any kind of symptoms, you know, come and see me, so he could see if and potentially help out. So we have a box of medicine here, so we would have albendazole for helmet infections or paracetamol for fever, or he would give an indication if somebody may have malaria, or iron for women. So he could basically, or he could give somebody a prescription to go for other treatment, or send them to the hospital if he thinks so. So we don't only just do a leishmaniasis serology, but we run a general clinic at the same time. And that provides also quite a lot of goodwill for this study as well, so that when we go there, people know they can benefit from it as well. So that's the case detection work that's going on. Let me talk briefly about vector control. India still uses DDT because it's quite effective at dealing with sandflies. And so currently, there still is a program where you have, it's more of a focus program. Wherever you have a high caseload, the strategy is to try and do more spraying in those villages than in areas where you have low caseload. I'm not too sure how well it's working. Organizing spraying of DDT in thousands of villages is a very difficult thing and very expensive as well. So this is something that really is very difficult to do properly. Nepal also has a spraying program of pyrethroids. Bangladesh doesn't have a spray program, or at least it didn't have a spray program up until very recently. But what we did there, Dr. Mondal, a couple of years ago, he set up a study, again with TDR WHO, where all of the people brought their bed nets, because they do use bed nets quite commonly in Bangladesh, where they brought it and dipped their bed nets in a pyrethroid solution, and then they slept under the bed nets with pyrethroids to kill the sandflies. And then the study was done to compare villages that had undergone this dipping process to villages that didn't do it. And in fact, in this particular study, there was quite a dramatic reduction in visceral leishmaniasis. So having pyrethroid-treated bed nets in the houses has had quite a significant impact, at least in this study here. So bed nets with pyrethroids appear, or there's good evidence that this does reduce transmission and visceral leishmaniasis. The next step that we're looking at through a TDR study is to use, instead of using a bed net to put over the bed, which is only there when you're sleeping, but you can actually take a material and put it on the walls of the house. So you've actually sort of put the whole house underneath protection with sort of this kind of material that comes in large rolls. And you can see it's on this house. More likely, it usually looks like this when you put it up on the house. But in these houses, all of the vectors are gone. Mosquitoes are gone, bed bugs are gone, sandflies are gone. So it's not only targeting VL, but any other kind of vector transmission that occurs in these areas. So this is a study that's ongoing right now. Initially, we're looking to see, we're measuring sandfly levels, but we're also measuring, and what's very important is acceptability. Are the people going to accept to have these in their houses? Because this is another major part. If people don't like it in their house, it's not going to be very successful. Diagnosis and treatment at the community level. So it's fairly easy to carry out what's called camps, or camp where you go in there and you try to identify visceral leishmaniasis cases. And this is Dr. Das. And what you do is you can set up a mat on the ground within the village, and you say, anybody who's got chronic fever, come here and we'll palpitate the spleen and see if you have enlarged spleen. So this is what Dr. Das is doing here. And if he has chronic fever and he has evidence of splenomegaly, then the RK39 test is done to see if he's got antibodies against a parasite. And if he fulfills those three criteria, then he's treated for visceral leishmaniasis. So it's a fairly simple thing to be done, running these types of camps, just going into a village and identifying cases like that. So this is a typical diagnostic lab that you would find at one of the primary healthcare centers. So this is the RK39 test. I'll just show it here. So what it takes is, it's a small strip like this. I'm sure many of you have seen it. You put a drop of blood on the strip. You put on your solution. You wait 10 minutes. And within the blood, you have antibodies against Leishmania. And if you have antibodies, then you have a positive test here. This is just a control line here, and this would be a negative here. So you can see typically in this person, you can see has a very strong reaction here. This is where the RK39 protein is. So most people who have leishmaniasis produce antibodies against this protein called RK39, which is present on the strip here. And you can see if they have antibodies against it, you have a very strong reaction here. These were all negative people. So this is the diagnostic lab that's set up. So this is an RK39 test strip. You see you also have glass slides here, and this would be for doing malaria smears or doing sputum for TB. So the three major ones which are being tested in this particular lab were malaria, TB, and VL. So it can be done quite rapidly at the primary healthcare center. Treatment. Let me just briefly talk about treatment. This is a study that was published by Shyam Sundar in 2010. This is one of the most important studies, and I think we have at least one person here from Shyam's lab, where he identified that people could be treated with a single dose of AmBisome. That doesn't mean you have to go back and be treated over and over again, but you can actually go and have one infusion of AmBisome, and in this study it showed 95% cure. The problem with AmBisome was that it was just too expensive to use. So even though it worked very well, it's of very little value if nobody can afford to use it. But WHO, because of this study, WHO made a negotiation with Gilead to bring the price down. And this is the box that contains AmBisome. So this is donated by Gilead. It has AmBisome. It says not for profit because this is actually a very expensive drug. And you can see it says here, this supply is for visceral leishmaniasis in the developing nations. So Gilead agreed to bring the price down to what was comparable for other drugs. So it would be similar to the cost of miltefosine, for example. So this was a major, this study together with this negotiation has now brought AmBisome available to India, Nepal, and Bangladesh. And the first country that's really taking it on is Bangladesh. But you can't take a drug like AmBisome and say, okay, here it's now inexpensive, just go and use it. You've actually got to show that this drug can be used under normal conditions in a country like Bangladesh or India or Nepal. So this is a study that we set up with TDR, which was a training course in good clinical practice for AmBisome. And we had several doctors who work at the primary healthcare center to be trained how to use AmBisome. And it's done under GCP conditions. So anytime you do a training, it has to be done under GCP conditions, as was set up here. And so these are in Bangladesh where they're being trained how to use AmBisome. So it comes it has a powder in a bottle, and it has to be diluted in dextrose solution, and it has to be diluted based on the weight of the individual. So there is some manipulation that has to be done before it's distributed. We're not the experts in using AmBisome, but Dr. Sundar was, so we actually had Dr. Sundar come from India to Bangladesh and provide the training. So even though we may not be the experts in how to train people, we make sure we do have the experts do the training. And Dr. Sundar was the one who came and provided the training. And you could see this. So this is the first patient who was treated with a single dose AmBisome in Bangladesh. This was the first child that was treated with AmBisome in Bangladesh during this training program. And I can say that Bangladesh now, this is the frontline drug. So if anybody has visceral leishmaniasis, they use single-dose AmBisome. And the people are really happy to be treated this way because they can be diagnosed and treated and cured in 1 day. So this is something that's quite remarkable, that there are very few diseases you can manage this way. And it's working very well. This has been adopted by the government in Bangladesh. Nepal is in the process of moving to use it, and I think India will as well, are also in the process of moving in that direction. So I'll just summarize the activities. So if we look at the three approaches of case detection, vector control, and diagnosis and treated, the idea was to move as close to the village as possible. So the farthest we go from the village is to the primary healthcare center, which is about 10 to 15 kilometers away. So people who are identified by Ashas or other means, they go from the village to the primary healthcare center. There's drugs available now. They can be diagnosed and treated with it. So they get treated at the primary healthcare center and they go back to the village. There's also new vector control strategies which are being tested. But all of the focus is now at the village level and at the primary healthcare center. About 5 or 6 or 7 years ago, this wasn't the case. If someone had the disease here in the village level, they usually went to a quack and they usually died. Sometimes they would go from the village to a district hospital or a private hospital and be treated, but the distance was quite large and many people just weren't able to do that. Philippe gave you the wonderful graph, which is really fantastic, I think, of the number of cases going down in these countries, particularly India, Nepal, and Bangladesh. And I would argue this is not a cyclical event. This event is occurring because people now can be treated at the primary healthcare center. And that wasn't the case 5 or 6 years ago. And the more people you move for treatment, the more you bring down the reservoir, the more the number of cases go down. So I would be very surprised to see a rebound because now treatment is so much more available than it was 5 years ago. So I think this has been a really successful campaign of elimination. And as of June 2014, the VL elimination target has been reached in Nepal and Bangladesh. It doesn't mean it's eliminated there yet, but the target is there. You have to verify that over a 3-year period. But the target has been met in Nepal and Bangladesh, and the number of cases are dramatically coming down in India as well. So I think the progress, the numbers really do speak for themselves, and I think they speak volumes. And I think it's largely, the most important factor as far as I'm concerned is that treatment is available at the primary healthcare center. So this is just the last slide. So we're coming to the stage now where at one point people would say, you're never going to reach elimination. It's not possible to do it. Well, I can tell those people now, yes, we can reach elimination, and it is possible, and we are doing it. But the thing is, what happens when you reach elimination? What do you do then? Because what I was saying is that you still have a lot of cases. So for example, in Nepal, this is the area where most of the cases are, and this is because this is the part that actually borders with Bihar. But they've reached a target of 1 case in 10,000. But there's still hundreds of cases here. So there still has to be a plan of what to do next. And one of the things that I think is quite interesting, as the number of cases have come down here, elimination has been reached in this area, something that's really interesting is happening. All of a sudden we're seeing cases, like a case in this part of Nepal, which has never had visceral leishmaniasis before. This is another case, another case, another case, and these have just popped up in the last year. And I think what's really interesting is that normally when you have a new case is developing, they normally is a focus of cases where you would have 5 or 6 cases or 10 cases. But in these situations, it just seems to be one case. And it's very hard to understand why all of a sudden you have a single case here. And these are people which has been confirmed that these people did not travel here, pick up the disease, and go back. So how did these cases get there? So that's, I think, I don't think we understand everything about transmission. I think that there's still some unknowns. One argument is that asymptomatic people went here and then went back here. So we're trying to see if we can follow up that to see if there's any evidence of that. But it's very hard to sort of track that down. But that's probably the only explanation we can have for this. But then that would mean that you'd have to have an asymptomatic person go from here, back here, transmit it here. This person going another time here, another time here, another time here. So why is it all of a sudden happening when it didn't happen last year, the year before, or previous to that? So I think as the number of cases come down and we reach elimination, we're going to start seeing things that we don't quite understand, or we're going to see new questions coming up. And this question here, I think, is going to be a very interesting one, because we're probably going to have similar things happening in Bangladesh and India as well as the number of cases come down. So if we can try to understand this, this could be important to maintain the elimination. So I'll just end off just a few acknowledgments. This work, of course, we've worked closely with a number of countries, particularly Sham Sundar, Pradeep Das. These are two real leaders in leishmaniasis. Nepal, Suman Rijal, Bangladesh, Dinesh Mandel. My colleagues at McGill. I didn't talk about work in Sri Lanka, but I'll talk about that in my next talk. Sri Lanka is an incredibly interesting place to study leishmaniasis. I'll talk about this in my next talk as well, but we collaborate with Peter as well. One of the things I think, and this is something you can all think about, is you all have very interesting parasites, much more interesting than the ones that people normally work with in the laboratory. And one of the major tools we have, and this will be good for tomorrow's workshop as well, is that you can really characterize these parasites very well now through the different genomic approaches. And I think that's going to be also important as we go forward to understand why some parasites cause different pathologies, or why different parasites can be transmitted. And a lot of that technology is really developed by Peter at the SBRI, so tomorrow's session will be really interesting, and some of the funding agencies for some of the work I've discussed. I'd really like to acknowledge, though, the work and the support from the World Health Organization. I think they've really been a leader in, I don't think the elimination would be anywhere near where it was if it wasn't for the support of the WHO, TDR, and Philippe, who really spearheaded that work for many years. So I'm happy to stop and answer any questions.